So we are live.
Good evening. Welcome to iFocus lecture 72. Today is the last in the series of our international cornea masterclass lectures, and we have saved the best for the last. That's Professor Rapuano from VZV Hospital, Philadelphia. He'll be speaking to us on herpes anterior segment disease. I would request Rolika to introduce him, following which he can share his screen. Rolika, ready?
Yes, sir. My screen is visible, sir.
Yes.
Professor Christopher Rapuano, an internationally recognized expert in corneal diseases, is the chief of the VZV Cornea Service and a professor of ophthalmology at Cenegermin Medical College of Thomas Jefferson University, Philadelphia, USA. He attended college at Brown University, medical school at Columbia University, completed his residency at VZV Hospital from 1987 to 1990, and a corneal fellowship at the University of Iowa from 1990 to 1991. Since 1991, he has been on staff in the cornea department at VZV Hospital. Dr. Rapuano is the author of several books, numerous book chapters, and more than 250 articles in the peer-reviewed literature on corneal diseases, refractive surgery, and excimer laser (PTK) surgery. Right during his ophthalmology residency, Dr. Rapuano co-authored the best-selling textbook in ophthalmology, the VZV Manual. He is also the series editor for the VZV Color Atlas series, previous editor-in-chief of the Yearbook of Ophthalmology, and actively serves on the editorial boards of several peer-reviewed ophthalmology journals, including Cornea, American Journal of Ophthalmology Case Reports, Expert Review of Ophthalmology, and Current Opinion in Ophthalmology. Among his many accomplishments, Dr. Rapuano has received the Honor Award, Senior Honor Award, and Secretariat Award 4 times from the American Academy of Ophthalmology. Dr. Rapuano has served on many committees of the AAO, including chairing the Refractive Surgery Basic and Clinical Science Course Book and Preferred Practice Patterns Committees. He is currently on the AAO Board of Trustees and is the AAO Senior Secretary for Clinical Education. It is an honor to have Professor Rapuano deliver a keynote lecture as part of the International Cornea Masterclass Series at iFocus Online, the Indian Ophthalmology Residence Education Program. We welcome you, sir. Thank you for taking out time for us.
Thank you very much for having me. Let's see. Okay. Is my title screen up? Does that look good?
Yeah,
Yes,
looks
sir.
good. Yes, you're
Okay. Thank you very much, Dr. Hanavar, for inviting me to give this talk. I'm going to talk about the management of HSV and VZV anterior segment disease. Talk will be, my guess is around 45 minutes to 50 minutes, and I'm more than happy to take questions at the end. I do work with several companies, including Biotissue that makes Procera, Dompe makes Oxervate, and Novartis makes Famvir. The herpes simplex is one of the most common infectious causes of decreased vision in North America and probably around the world too. Humans are the only natural host of HSV. Comes in 2 forms. Type 1 typically causes ocular and facial herpes, whereas type 2 tends to cause genital herpes. And about 90% of the US population has antibodies to HSV1 by the age of 15 or 20 years old. Primary infection tends to occur in childhood. It often appears as a mild flu. Patients may or may not have skin blisters or any eye findings at the time. People don't even know, for the most part, that it has anything to do with herpes simplex. It comes, it goes, usually without treatment, and may never come back again. But the virus remains dormant in the trigeminal ganglion. This is a picture of a child with primary herpes simplex. And with primary disease, you can certainly have bilateral involvement. Most of the ocular HSV infections that we encounter as ophthalmologists are recurrences. The triggers of recurrences are pretty kind of overall unknown. Having said that, a lot of people feel that they may be due to stress, whether it's physical stress or emotional stress, or sometimes ultraviolet exposure or menstruation. But in the kind of studies that have been done, it's pretty hard to kind of really pin down distinct recurrence triggers. Now, how does it show up? It shows up all over the eye. It can show up in the eyelids, as we've already seen, as blisters in the eyelids. It can show up in the conjunctiva. You can have a follicular conjunctivitis. You can also get a dendritic ulcer in the conjunctiva, but it does not look like a classic herpes dendrite of the cornea. It doesn't have the same terminal end bulbs. It just doesn't look the same. If you're looking for a classic dendrite, it doesn't look classic on the conjunctiva, but you can see kind of linear and branching staining. Here is a patient of mine who unfortunately has bilateral herpes simplex, and here she has bilateral herpes simplex dermatitis, and also, around her lips you can see too. Here's another patient with kind of a herpes lesion of the eyelid, and higher mag you can almost make out to see maybe it's a little dendritic pattern there. Here are two different patients with kind of excoriated eyelid margins in patients with known herpes simplex, and sometimes they have had herpes simplex infections in the cornea, so we've been sure that it's been herpes. Now, here is a herpes dendrite right at the limbus, and you can see it's not a classic, tree branching dendrite that we see on the cornea. So at the limbus on the conjunctiva, it's not classic, but this is certainly herpes in this eye in a patient with known herpes simplex. Now in the cornea, very mild cases, you can just get a punctate epitheliopathy. And certainly I'm going to show pictures of classic dendritic keratitis and geographic keratitis, which is basically where dendrites kind of enlarge. You can get immune stromal keratitis, disciform endotheliitis, necrotizing keratitis, and neurotrophic keratopathy. It also causes iritis and retinitis. I will not be talking about the retinitis today. So dendritic and geographic keratitis, this is active viral infection in the cornea. And here's a classic, relatively small, but a classic dendrite with this kind of tree branching pattern and little terminal end bulbs. Here too are multiple small dendrites and a cornea stained with rose bengal. This is a photo of my former senior partner, Peter Lapson. There's another photo of Peter Lapson where the dendrites are kind of expanding a bit and becoming what's called a geographic dendrite. Here are dendrites in both eyes of the same patient at the same time. It's unusual to have bilateral herpes keratitis. It happens maybe 5 or 7% of the time. It's rather unusual to have dendrites in both eyes at the same time. Now, here's a couple of small dendrites centrally. They can also have inflammation in the cornea. You can see some KP just below the dendrite. And there the dendrites in higher mag with fluorescein staining are quite prominent. Now, here is a large dendrite with multiple kind of branches off it that it's enlarging and becoming a geographic dendrite. And here's a patient who's obviously had a cornea transplant, happens with a full thickness transplant for herpes simplex keratitis scarring, and now has a huge geographic HSV dendrite. You can see the edges look dendritic. There's another patient with known herpes simplex keratitis. You get this sense that there's something going on here, but then when you stain with fluorescein, you can see this is a large geographic dendrite, a little bit of the kind of a tree branching pattern at the edges. I like this picture because it looks like a dragon to me. So how do we treat this dendritic keratitis and geographic keratitis? Well, since this is an active viral replication, active infection, we treat it with antiviral medications. You can use oral antivirals such as acyclovir, 400 milligrams, 5 times a day, kind of the full HSV dose, or you can use topical antivirals. There's ganciclovir gel, and acyclovir ointment, that's which is used about 5 times a day. We can also use trifluridine drops. In the US, it's FDA approved at 9 times a day. Around the world, it's often used at 5 times a day. Unfortunately, the trifluridine drops are much more toxic than the ganciclovir gel or acyclovir ointment. In general, whether you use oral or topical treatment, I follow them up in usually about a week if it's not terrible, and a little earlier if it's really, really bad. I want to make sure they're getting better. And then at a week, they're usually improving, and I'll usually cut the medicines in half, cut the topical medicines in half after a week and stop them in 2 weeks. If it's an oral medication, I'll usually continue that at the full dose until it's completely resolved. After 2 weeks, the active viral infection is almost always gone. There may be some residual staining or epitheliopathy, and that's often from medication, especially topical medication toxicity. Resistance to these antivirals in dendritic keratitis is pretty low. Here's what I call a ghost, or actually Peter Lapson taught me to call a ghost dendrite. There was a dendrite here, the dendrite resolved, but you've got a little stromal inflammation in the pattern of a dendrite, so he's termed it a ghost dendrite. Now, what else can you get with herpes simplex in the cornea? Well, you can get an immune stromal keratitis. This is an inflammatory reaction in the stroma, and it's thought really not to be an active infection. The mild form is the haze after a dendrite, that ghost dendrite I talked about, but you can have a much more severe form where you can get a stromal infiltrate where it's whitening, different from edema. I'll show you in a minute. It's a stromal whitening. They may have an immune ring. They may have corneal neovascularization. If they have neovascularization, they may have lipid deposition. And they may also have an anterior chamber reaction in conjunction with the immune stromal keratitis. So here's a patient with, you can see this whitening in the cornea with known herpes simplex. And in higher mag, we can see that there's neovascularization coming from kind of the 330 location. And this, with chronic neovascularization, you can get this lipid deposition. And a lot of what the white that we're seeing there is lipid deposition. And here's an eye with non-active, an old stromal keratitis. Can see that there's neovascularization, there's severe thinning at the superior edge of that, and there's lipid deposition, that whitening to the left side. Another form is disciform endotheliitis. This is an inflammatory reaction in the endothelium as opposed to the stroma we just showed, and tends not to be thought of as an active infection. They get stromal edema, not stromal infiltrate. So it's not whitening. You tend to be able to see through the edema better. They can have KP, but if there's severe edema, the KP may be hidden at the beginning, and once you treat them and the edema goes away, you can actually see the KP later. They may have an obvious AC reaction, but if there's a lot of edema, it may be hard to see that AC reaction. And these cases often have an elevated intraocular pressure, probably from an inflammatory trabeculitis, where the trabecular meshwork just gets clogged up and the pressure goes up. And what I tell all our residents and fellows, if you have an elevated intraocular pressure in the setting of iritis, you have to think of herpes, whether it's herpes simplex or herpes zoster, as the reason for the iritis. Because typically, iritis lowers intraocular pressure. And here's just a mild endotheliitis, and you can see the KP there. And here with a slit beam, you can see that there's stromal thickening and stromal edema and KP. Here's a more classic disciform endotheliitis, where they have this kind of disc-shaped edema in the central part of the cornea. Doesn't always have to be in the central part, but it usually is. And those white dots are kind of large KP on the endothelium. And here too, you can see the cornea is thickened and edematous. Now, you could have herpes simplex iritis, where basically the iritis is the main manifestation. Here they have an obvious AC reaction in KP. They may even have a hypopyon, or they may have a small hyphema, or hypopyon mixed with a hyphema, because the iris, the blood vessels in the iris are rather fragile. They can have focal ischemia of the iris, and that can cause iris atrophy and iris transillumination defects. They may have an associated stromal keratitis or edema along with the iritis. And again, they often have an elevated IOP from this trabeculitis. And if you have an elevated IOP with iritis, you have to think of herpes. Here's a patient I saw with known herpes who came in recently complaining of decreased vision. And sure enough, he had a severe iritis and elevated intraocular pressure. And you can see those kind of KP over the inferior half of the cornea. There's another patient with diffuse stromal edema, KP, and actually a small hypopyon and elevated intraocular pressure from herpes-related immune stromal keratitis, endotheliitis, and iritis. There's a patient with resolving HSV-related iritis. The KP are actually going away with treatment, but with retroillumination down at 3 o'clock and 4 and 5 o'clock, you can see the iris transillumination defects from kind of chronic episodes of inflammation of the iris and iritis. So how do we treat the immune stromal keratitis, the disciform endotheliitis, and iritis? Well, basically, since it's an inflammatory reaction, we treat it with topical steroids. And depending on the severity of the inflammation, you can use something like Predforte or prednisolone acetate 4 times a day, all the way up to every hour. And then it's slowly tapered over months. A mistake that is often made is these steroids are tapered too quickly, and then there are continued flare-ups of the inflammation. Often we'll use an antiviral at the same time, basically to prevent viral infection from either coming or getting worse if they happen to have a flare-up. You can use kind of the prophylactic dose, something like acyclovir 400 twice a day, or the treatment dose, 400 milligrams, 5 times a day. And certainly we will use that if they have iritis, because the HEADS trial showed that it was probably somewhat effective. The inflammation does not go away quickly. It can take weeks or months to resolve. Now, the next form of kind of herpes corneal problem is a necrotizing keratitis. Fortunately, this is a rather unusual and often rare condition. It's probably a combination of active viral infection and active inflammation in the corneal stroma. They have corneal ulceration, and they can have melting, and they can have perforation. You need to rule out other infections. They could certainly have a bacterial or fungal infection at the same time. So they might need cultures and antibiotics. But these patients get aggressive treatment dose antiviral therapy, and then also anti-inflammatory therapy, and maybe antimicrobials at the same time. Here are here's one patient with the broad beam in the top and the slit beam in the bottom with a necrotizing keratitis from herpes with thinning in the central part of that keratitis. And lastly, you have a neurotrophic keratopathy. This presents as a persistent epithelial defect without an active viral infection. So different from the necrotizing keratitis we just saw. Here, it's often a fairly quiet eye, and they have these rolled up, smooth, gray epithelial edges, often in the inferior half of the cornea, and it's related to nerve damage to the cornea from the herpes virus. Here's a pretty classic, large neurotrophic epithelial defect with those rolled up edges. And here's another one more in the inferior half of the cornea and with significant corneal thinning. And the causes sometimes can be related to antiviral medication toxicity, just chronic low-grade inflammation, but generally it's related to a neurotrophic cornea, poor growth factors, poor blink, lack of wetting, perhaps possibly repetitive trauma, patients rubbing their eye, they don't feel their cornea and they're actually rubbing it. All damage here from either the active HSV virus or the treatment for it. How do we treat neurotrophic keratopathy? Well, you can see there's a list of maybe 8 or 9 things here. Whenever you have a list of 8 or 9 things to treat something, it's because one thing doesn't work super well. But we kind of do this stepwise pattern, stepwise approach, decrease the toxic medications, aggressive lubrication, judicious steroids. If it's not that inflamed, then steroids probably aren't going to be that helpful. If there's some inflammation, steroids may be helpful, but you have to be very careful that steroids aren't actually aiding to corneal melting. Autologous serum can be helpful. A bandage lens can be helpful. We'll often use a self-retained amniotic membrane, such as on a Procera ring or under a bandage contact lens. Certainly a glue or suture tarsorrhaphy can be very helpful. And if it's getting even worse or not responding, you can suture or glue amniotic membrane. And then a last-ditch effort would be a conjunctival flap. Now, the newest treatment on the block for neurotrophic keratopathy is Cenegermin. It's Oxervate made by Dompe. This is recombinant human nerve growth factor. It was FDA approved at the end of 2018, and we've been using it for 2 years here in the US. It's 1 drop 6 times a day for 8 weeks. It's obtained through a special kind of designated pharmacy. The phase 2 Rapuano study was a study that was used to get FDA approval. It's on about 150 patients randomized to Cenegermin or placebo, and they were looking for 100% healing at 4 weeks and 8 weeks. And in the treatment group at 4 weeks, between 50 and 60% were 100% healed. And by 8 weeks, 63 to 72% were 100% healed, where in the placebo group, it was only 14% or 33% completely healed at 4 to 8 weeks. And we have found this to be a very, very, very effective medication for the treatment of neurotrophic keratopathy. The big downside is its cost. At least the cost in the US is over $90,000 for an 8-week course. Needless to say, nobody can actually pay that. So we have to go through their insurance company and the Dompe and go through a process which can take several weeks to get the medication approved. But fortunately, we've been able to get it approved on about 95% of the patients we've tried, and it's quite effective. Here's what you want to avoid. This is a patient with chronic HSV keratitis, neurotrophic keratopathy, and a melt and a perforation. Here's a patient with HSV neurotrophic keratopathy treated with a Procera ring. Here's a patient who's been treated with a conjunctival flap. Now, how do we prevent herpes from coming? Well, the herpes eye disease study, the HEAD study, showed that long-term oral acyclovir, 400 milligrams twice a day, decreased the recurrence of HSV by 50%. While 50% is very good, certainly it's not 100%. It's especially effective in patients who've had multiple episodes of stromal keratitis. So after they've had inflammatory keratitis, patients often need to be on low-dose topical steroids for years. As I mentioned earlier, one of the mistakes that's often made by treating doctors is they taper the steroids too quickly, herpes simplex, especially in herpes zoster, which we'll talk about. These infections may resolve with or without scarring. If it's scarred, sometimes you could treat them with an excimer laser PTK if it's very superficial scarring. If it's irregular scarring and not too much opacity, sometimes a rigid contact lens can be helpful. And if not, they might need a cornea transplant to get better vision. So here's a patient with some mild scarring after herpes simplex keratitis. Here's a patient with a little bit more severe scarring after herpes keratitis. Here's a patient with severe scarring after herpes keratitis. So when we're talking about surgery, we want the eye to be quiet for at least 6 months prior to any corneal transplant, and longer, maybe a year is even better. If the scarring is in the top half of the cornea, if the scarring is in the top 10 or 20%, excimer PTK can be helpful, but if it's deeper than 10 or 20%, you need some type of cornea thickness. If it's in the top half of the cornea, you can try half thickness anterior lamellar graft, such as a hemi-automated anterior lamellar graft or femtose second laser assisted lamellar graft, or of course a deep anterior lamellar graft or a full thickness penetrating keratoplasty. I use prophylactic oral antivirals in all my patients who've had herpes, keratitis, and get a cornea transplant. Acyclovir 400 milligrams twice a day typically. How long do we use it? Well, some people used to say 3 months, then 6 months. For my patients, I tend to use it for at least a year, and if they're tolerating it well, I may keep them on it forever. In addition, when I do transplants on these patients, I do a temporary tarsorrhaphy at the time of the transplant to help with epithelial healing postoperatively. It's much easier to do at the time of surgery than 2 or 3 weeks later when they're having a hard time healing. Here's a patient of mine with relatively anterior corneal scarring that I want to avoid a cornea, full thickness cornea transplant. So I did a hemi-automated lamellar anterior transplant that was about 50% cornea depth. This is postoperative day 1. You can see the new cornea on top and the patient's own cornea down at the bottom there. Now, what about herpes simplex, keratitis, and cataract surgery? Well, there's several concerns. One concern is corneal scarring. Sometimes the corneal scarring cannot seem so terrible at the slit lamp, but then when you lay them down under the operating microscope, the view may be much worse in the operating room. So I've had patients who have been taken to surgery and then the surgeon could not actually start the surgery because the view wasn't good enough and sent them back to me for a cornea transplant. They also often have irregular astigmatism. They'd be very cautious about using a toric IOL, especially if they may use a rigid gas sperm contact lens after, or a toric IOL if you may need to do a cornea transplant after. Neurotrophic keratopathy is another concern. Recurrent inflammatory keratitis or iritis is another concern. And of course, recurrent HSV infections can happen after cataract surgery. So we want them to have no active keratitis or inflammation for at least 3, maybe ideally 6 months before any cataract surgery. Here too, I'll use prophylactic oral antivirals. And then they often need more steroids than usual after the surgery because they're prone to inflammation and they're tapered more slowly than usual. And you have to remember to stop the taper at the pre-cataract level. So if they were on chronic Pret Forte once a day for years, they get cataract surgery, the steroids are bumped up, they go on a taper. Oftentimes the cataract surgeon will forget that they were on the once a day steroid, and then they'll stop the steroid after 2 or 3 months, and then that risks increasing another inflammatory keratitis. And of course, you want to minimize epitheliotoxic medications, especially NSAIDs. So in summary, HSV dendrites are treated with topical antivirals or full-dose oral antivirals for 7 to 14 days. Immune stromal keratitis, disciform endotheliitis, or both of those are treated with aggressive steroids, plus or minus oral antivirals, but these days we're pretty generous with the oral antivirals in these cases. Iritis is treated with aggressive steroids and full-dose oral antivirals until they're improving. If they have a history of multiple episodes of HSV, especially stromal keratitis, or if they've had a transplant for HSV, they get on prophylactic antivirals for many months, if not years, if not forever. And in general, when tapering steroids in eyes that have had HSV keratitis, they're tapered very, very slowly. And the goal is to get them off, but sometimes you just can't get them off of their topical steroids. And they may be on a once-a-day mild steroid such as fluorometholone or loteprednol, or sometimes I have people on every other day or 2 days a week, and they do well on 2 days a week, but as soon as you stop it, they get a flare-up. So you have to keep that in mind. Okay, on to varicella zoster virus. As you know, this is the virus that causes chickenpox after primary infection. It causes a self-limited vesicular rash. The virus migrates to the sensory ganglia and has a latent phase similar to HSV. I have 4 kids. 2 of my kids got chickenpox, but my 2 younger kids ended up with the chickenpox vaccine, so we actually see chickenpox a lot less commonly these days. Chickenpox rarely involves the eye. They can get this vesicular rash on the eyelids that can scar, so have to be careful. They can get vesicles on the conjunctiva or the limbus, and the cornea can get punctate staining or dendrite or disciform keratitis, although these are very uncommon with primary chickenpox. Here's a patient that I did see when I was a resident at Wills many, many years ago, had active chickenpox and had a actual chicken pock at the limbus, infero-nasally there. What we see is the varicella zoster virus that can reactivate years later. Okay? Typically, it causes a vesicular dermatomal rash, what we call shingles. Shingles is most commonly on the trunk over half the time, but 15 to 20% of the time can involve the trigeminal ganglion, which leads to herpes zoster ophthalmicus. And we think of it as a unilateral condition, which it 99% of the time is, but it's rarely, maybe 1% of the time, bilateral. And over half of these will involve the eyeball when it's in this V1 distribution. In the US, it's said to be that zoster occurs in 1 million patients a year, about a 30% lifetime incidence, and it's been increasing over the past couple decades. And used to be said there was about a 1% chance of recurrent zoster, and now it's said it's about a 5% chance of recurrent zoster. And I've had patients who have had actually third episodes of zoster in different dermatomes. The risk increases with age. It's higher in HIV positive patients and other immunocompromised patients. And as I mentioned, the incidence of zoster is rising since 1993 worldwide. Right? Maybe it has to do with the widespread Varicella zoster, Varicella zoster chickenpox vaccines, which began in 1995. Maybe related, but maybe not, because the incidence is also rising in countries that did not start these chickenpox vaccinations anywhere near that early. As you know, there are 3 divisions of the trigeminal nerve. The ophthalmic division is most affected, the frontal nerve most often. You get the rash in the upper lid, superior conch, forehead, and scalp. When the nasociliary nerve is involved, you get the rest of the conjunctiva, sclera, uvea, and the tip of the nose. When the tip of the nose is involved, it's called Hutchinson's sign, and it's said to double the risk of actual ocular disease. How does it affect the eye? Well, you can get a dermatomal rash that leads to scarring. The skin rash tends not to cross the midline. Having said that, the edema can cross the midline. So sometimes you'll say, oh, it's not zoster because they have this edema that's all the way on the other side, but that's not necessarily true. So the edema can cross the midline, the rash tends not to cross it. Shingles is often preceded by tingling, burning, warm sensation for a few days prior. And we also have a prodrome of fever, chills, or malaise. The story I often hear is a patient gets pain around the eye, skin around the forehead, and they go to their doctor or they go to an urgent care, and they're diagnosed with sinusitis or something. They're given either steroids or some skin cream, and then a couple days later they come down with the rash. And it was definitely, shingles a few days before, but sometimes it's often difficult to recognize. In fact, I saw a patient just yesterday who was treated a week ago at an urgent care for sinusitis with oral steroids, and 3 days later came down with a classic shingles rash, and the steroids were then stopped and they were started on antivirals. The vesicles can last 2 to 3 weeks, but they can often cause scarring when they go away. If it's severe, it can cause lid necrosis, and then the damage to the eyelids can cause trichiasis, lash loss, atropion, ectropion, and any of that can also precipitate corneal scarring. And then they can get postherpetic neuralgia, which we'll talk about in a little bit. Here is a patient who has a mild shingles rash, was caught very, very early, put on oral antivirals and did very well. There's a patient with a little more of a prominent shingles rash. You can see it's just staying on one side, unilateral. Here's a patient with a much more severe shingles rash, again, one-sided. Another pretty severe shingles rash, one-sided. And it can occur in children. Here's a relatively mild shingles rash, one-sided. And here too, more severe shingles rash in a child. How does it affect the eyeball? It can affect the conjunctiva. You get hyperemia, you get a follicular or mucopurulent conjunctivitis, you get episcleritis, scleritis, you get an iritis and a trabeculitis. But the cornea is what we see most often affected in shingles. You can get just SPK, you can get a microdendritic epithelial keratitis. That can occur very early on. They get microdendrites, tiny dendrites, can be all over the cornea, and they can look like herpes simplex dendrites, although they tend to be smaller and more diffuse. And you can actually culture varicella zoster virus from those. And then they go away on their own. And then later on, you get these delayed onset mucus plaque pseudodendrites or mucus plaque dendrites that are elevated and they stain a little bit with fluorescein. They don't have terminal end bulbs. You can also get intrastromal infiltrates, get disciform keratitis endotheliitis, necrotizing keratitis, and neurotrophic keratopathy. Those last four are similar to what you can see in herpes simplex. SPK, and I mentioned these microdendrites can look like classic dendrites, tend to be more peripheral and numerous. They clear without treatment. They may leave some haze, and you can culture virus from them. And this is a patient of mine who has these little microdendrites all over the cornea, and we actually suspected herpes simplex when we saw this, but 2 days later came down with a classic herpes zoster rash, and these went away on their own. The delayed onset mucus plaques or pseudodendrites are a little bit more troublesome. They can occur weeks to months later. As I mentioned, they're elevated, they're coarse, they're somewhat branching, kind of this dendritiform, but no terminal end bulbs. They appear to be stuck onto the cornea. They're sometimes self-limited, but they can last months, and they can be painful. And obviously, if they're in the center of the vision, they can affect the vision too. So here's a patient, the same cornea with white light and with the cobalt blue light with these mucus plaque dendrites. You can see it's got this dendritic pattern to it, but not a classic dendrite. Here's another one in the top left, kind of very classic pseudodendritic pattern there. And in the bottom right, more of this elevated mucus plaquey pseudodendrite. How do we treat them? Well, lubrication, topical steroids, but often they're just transient and they can last for weeks and then go away. Some doctors will debride them. Sometimes they peel off the epithelium reasonably well, and sometimes they're really, really stuck on. You end up with a large epithelial defect and they can recur after that. Sometimes topical antivirals can work. When vidarabine ointment was around, that seemed to be very effective. Ganciclovir gel, Zirgan gel can also be very effective. These antivirals may be better, may be more helpful in immunocompromised patients. Oral antivirals may work too. Some of my colleagues at Wills find the oral antivirals very helpful. I don't find them as helpful, although I will use them in immunocompromised patients. Immune stromal keratitis and endotheliitis, similar to HSV. These are inflammatory reactions to viral antigens. You can get the stromal infiltrate, disciform edema, KP, immune ring. Usually with an intact epithelium, they can lead to scarring, thinning, neovascularization, and lipid, and they're treated with topical steroids. They're inflammatory, treated with anti-inflammatory medications. As I mentioned, with herpes simplex, it's a slow taper, and with herpes zoster, it's an even slower taper than herpes simplex. And what I tell the residents and fellows here is when I started practice, I inherited a lot of patients who'd had shingles and were on very low dose steroid drops. That might have been something like FML once a week, or Predmild once a week, or Predforte once every 2 weeks. And I said to myself, that's crazy, that's doing nothing. So I stopped that low dose steroid on a lot of my zoster patients. And many of them came back within 3 months with flare-ups. And they said to me, Dr. Rapuano, why did you stop the medication when the prior doctor had me on it for 10 years? And my answer was, because I was stupid. I didn't understand that low-dose topical steroids in zoster can be helpful, even though it seems like it's a drop in the bucket. Of course, you can also get necrotizing keratitis in these patients too, just like herpes simplex. Here is disciform keratitis. I can see the edema there with KP. If I didn't tell you this patient had shingles, you could say, well, it could certainly be herpes simplex, and it sure could. Same thing here. Here's a kind of a more of a necrotizing keratitis from shingles. And here are two patients who have had shingles in the past, have had stromal keratitis, and have neovascularization and lipid deposition. Certainly get iritis too. It's granulomatous or non-granulomatous. And again, they can have hypopyon or hyphema and get that same focal ischemia and transillumination defects, and they can get glaucoma, this inflammatory glaucoma, just like herpes simplex. And again, here's a patient with an iritis, and if you didn't know that they'd had shingles, you could say it could have been herpes simplex, and it certainly could have been. And the neurotrophic keratopathy, just like you can get in herpes simplex, but it tends to be worse in herpes zoster. Maybe 25% of patients who've had herpes zoster keratitis will have significant neurotrophic keratopathy. SPK, epithelial defect, non-healing ulcer, scarring, vascularization, infection, perforation. Again, the lack of neurotransmitters, growth factors, poor tear production, poor blinking, lid changes, perhaps from lid scarring from the shingles, and then perhaps repetitive trauma. Here's a patient with a history of shingles who has a neurotrophic ulcer with severe thinning. And it's required an amniotic membrane graft and Oxervate to heal up. How do we treat it? We mentioned this earlier: lubrication, patching, fix any eyelid abnormalities, temporary or permanent tarsorrhaphy, amniotic membrane graft, conjunctival flap. If there's significant melting and perforation, they may need corneal glue or a patch graft or PK. And nowadays we're using Cenegermin or Oxervate, this recombinant human nerve growth factor, to try and prevent or treat neurotrophic keratopathy. And here's a patient with a corneal perforation that was glued in an eye with zoster. Now, how do we treat active zoster? Well, active zoster dermatitis gets a full course of systemic antiviral medications. It's FDA approved if you catch it within the first 72 hours, but I'll treat it anytime within the first week. And the full dose is acyclovir 800 milligrams 5 times a day, Valtrex or valacyclovir 1 gram 3 times a day, famciclovir 500 milligrams 3 times a day for 7 to 10 days. If they're severely immunocompromised, I'll admit them for oral acyclovir. Now, I checked just recently with how much this course, this 7-day course for zoster costs. For Zovirax brand name acyclovir, it's $600, but for generic, it's only $30. Brand name Valtrex is almost $500, but the generic's pretty cheap at $30. And Famvir is about a little over $500, but the generic's pretty cheap. My sense is that in India, these costs would be a lot less. Interestingly, I found an old lecture of mine where I also showed the cost of these medications. Back in 2005, generic acyclovir was only $16, so $30 isn't terrible. But brand name Valtrex was $69, and the price now is almost $500. And Famvir was only about $100, and now it's over $500. So it seems like there's been a lot of price inflation, at least with these medications. Why do we actually treat active zoster dermatitis and active zoster? Well, it decreases the acute pain, it shortens the duration of the skin lesions, decreases viral shedding and new lesion formation, probably decreases the stromal keratitis, uveitis, and maybe even the pseudodendrites. And at least Famvir and Valtrex decrease the incidence of postherpetic neuralgia. So it's critical to treat patients with active zoster dermatitis with these oral antivirals as soon as possible. Systemic steroids were used a lot in the past to prevent her postherpetic neuralgia, but not used so much anymore. I think the data on that's relatively weak for it being helpful, and rarely in immunocompromised patients, systemic steroids could actually cause disseminated zoster and be quite dangerous. And as I mentioned, any of the inflammatory complications are treated with topical steroids with a very, very slow taper of the steroids, a slower taper than in herpes simplex keratitis. Antiviral coverage is not usually required, but is it beneficial? That's a very good question. There's excellent data on the treatment of acute zoster, as I just mentioned, that 7 to 10 day course. There is no good data for the treatment of a recurrent zoster. There's no equivalent study to the head study for herpes simplex, which showed a 50% reduction if you're on oral acyclovir. Elizabeth Cohen, who is my former partner at Wills, has a big National Eye Institute and National Institutes of Health sponsored study looking at this. It's a gram of oral acyclovir a day versus placebo for a year, follow them for a year and a half to see whether this does reduce the incidence of problems from recurrent zoster. This study is ongoing. What about Postherpetic neuralgia? Well, depending on the definition, either persistent pain, either 1 month, kind of the classic definition is 3 months after onset. It's common. 60% of patients have pain, skin pain, pretty severe at a month. Fortunately, it goes down to 15% at 6 months. It tends to be more in older patients. It's only 2% if you're younger than 50 when you get the shingles, about 20% over 50, and 35% over 80. And this pain can be devastating type pain. People will describe it as burning, like flames or spears. And it's a leading cause of depression and suicide in older adults in the United States. Now, here too, you see, I don't know, 8 treatments here for postherpetic neuralgia. Whenever you see 8 treatments, it means that one treatment is not head and shoulders better than the others. We'll sometimes use capsaicin cream, which is a hot pepper extract, or lidocaine cream or lidocaine patch. Sometimes doxepin cream or gabapentin pills or pregabalin pills or systemic tricyclic antidepressants or duloxetine pills, cimetidine, nerve blocks, TENS, acupuncture. We'll often send them to pain specialists because they have access to a lot of these treatments. One of the reasons we really want to prevent shingles is because not only can it cause eye problems, but it can have systemic problems. The relative risk of a stroke after shingles is increased. Within the first month, it's increased 1.78 times, and over 2 times if they've had herpes zoster in the eye. After 3 months, it decreases to 1.4 times. After 12 months, 1.2 times, but there's an increased risk of stroke after shingles. There's also an increased risk of dementia after shingles. These are 2 big studies in Taiwan, where there's a 1.11 time increased risk of dementia with shingles, and in a different study, dementia followed for 5 years, there was an almost 3-time risk of dementia if they had shingles in the eye. So all great reasons to prevent shingles. Here's another reason. This is a personal patient of mine. It's a patient who had shingles. He was a young dentist, and we treated him, put him on low-dose topical steroids for years. He decided to ignore the recommendations, stopped his medications, and then finally came back 7 years later looking like this, ended up with a cornea transplant, but never got good vision, and had to stop being a dentist. So why do we've explained why we want to prevent shingles. How do we do it? Well, the first Varicella zoster vaccine was called Zostavax, at least in the US. Zostavax was a live virus vaccine made by Merck, FDA approved back in 2006. And it reduced zoster by about 51% and postherpetic neuralgia by 67%. That's pretty good. It's not great, but it's pretty good. But it was more effective in younger patients, less effective as patients got older. You had to stop antivirals, and there was contraindicated immunocompromised patients. It was a good vaccine, but not a great vaccine. The newest vaccine is Shingrix by GlaxoSmithKline. This is a recombinant subunit, so it's not a live virus. It does require 2 shots, and studies were done in patients 50 and older. The first big study published about 6 years ago, it was 97% effective, and it was the same effectiveness in all age groups. It was not contraindicated immunocompromised patients because it wasn't a live virus. Phase 3 trial with about 3.7-year mean follow-up. This one was done in patients 70 and older. The vaccine was about 90% effective overall, and was the same in 70 to 80 versus over 80. So combining the studies is about 88.8% effective against postherpetic neuralgia, and the Shingrix vaccine was FDA approved in the US just over 3 years ago for patients over 50, and I recommend it to all my patients over 50. So in summary, herpes zoster is common, and the incidence is increasing. It should be treated emergently with oral antivirals. They have the the dermatomal rash. Pseudodendrites may resolve on their own, but topical ganciclovir can be helpful, and maybe oral antivirals. The inflammatory keratitis or iritis requires a very long, slow taper of topical steroids, often without antiviral coverage. We don't know that yet. Postherpetic neuralgia can be severe and should be treated aggressively, and it may take a pain specialist. And the new Shingrix Varicella zoster vaccine is very effective and should be encouraged by all of us. Thank you very much for your attention. I'm happy to answer any questions.
Thank you so much for a wonderful lecture. Harika, do we have any questions?
Yes, so we have one question. How do you recommend to treat herpes zoster ophthalmic with intracranial extension, sir?
I'm sorry, repeat that?
How do we recommend to treat herpes zoster ophthalmicus with intracranial extension?
With intracranial extension?
Yes, sir.
Well, I mean, I don't treat patients with intracranial extension, but they would be admitted to the hospital and put on systemic antivirals, and I would have the infectious disease consult. And I don't know anything about intrathecal antivirals, but I would allow them to treat those patients. I do think you have to be very cautious and careful. Whenever I see a patient with zoster, I examine their eye, of course. I always dilate them to make sure that there's nothing going on in the retina or the optic nerve. Even if their eye's perfectly quiet, I will dilate all those patients at the time of the rash, time I'm seeing them the first time.
Thank you, sir. The next question is, till how many months do you expect post-herpetic neuralgia to fade away?
Well, there's there's certainly a high percentage of patients. I said 60% have it by 3 months and 50% by 6 months. If they still have it at 6 months, most of those patients, in my experience, will have it their whole life. It may diminish a little bit, but they will have it for a lifetime if they have it at 6 months. And if it's mild, they can use mild treatments. But if it's severe, I send them to a pain specialist because they can have clinical depression and actually kill themselves. People will describe this pain as some of the worst pain they've ever had in their whole life.
Okay, sir, thank you. The next one is, so you have enlightened about the cardiac complication post-infection. So how often do you recommend these patients to a cardiologist for evaluation?
Well, I send them to a cardiologist at the beginning so that they know they're at increased risk for these, and they allow the cardiologist to kind of follow them. I think probably it's just one of the increased risk factors that the cardiologist will then manage, and they may, if they had not had shingles, they may not use, let's say, a statin. And if they have shingles, they may say, oh, we want to be more aggressive and we'll use a statin in you. Or they may want to have the blood pressure a little bit lower with a history of shingles. I'll leave that up to the cardiologist, but I'll definitely tell the patient that they're at increased risk and they should see their internist or cardiologist and let them know.
Thank you, sir. The next one is, how do we follow this herpes zoster patients and what are the precautions we need to take to prevent recurrences?
So it depends on the amount of active inflammation. The more active inflammation they have, certainly if the eye pressure is up, then I follow them very closely. If the pressure's up, I may see them the next day or a few days later to make sure that the pressure's coming down, the inflammation is coming down. Then I will just slowly taper the steroids. And at the beginning, I will see them every week or two. And then as I slowly taper, it might be every month or two. If I have a patient, let's say they're doing well on twice a day for several months, and I want to decrease them to once a day, I may tell them, okay, use the steroid drop twice a day for 2 months, then decrease it to once a day, and I will see you a month later. So they're only on the once a day for 1 month so that I can evaluate them and make sure they're not flaring up. And then if they're on once a day doing well, I may keep them on once a day for another 3 or 4 or 5 months. And if they're doing well, I may decrease them to every other day after that. And I, of course, warn them, if you get more redness or light sensitivity or inflammation, you've got to come in right away.
Thank you, sir.
And the way to, I'm sorry, the next phrase, how do we prevent recurrences? Well, it's a slow steroid taper. That's the best way to do it. Obviously, if they're on steroids, they have to be monitored for complications of steroids, such as steroid response glaucoma and cataracts. But once they're monitored, it's a slow taper of steroids. And in my experience, it's not uncommon that I cannot get zoster patients off of steroid drops. They might be on FML, fluorometholone, every other day, or once a week, or twice a week. That's a lesson I've learned over the years.
Thank you, sir. The next one, is there any regimen you specifically follow to prevent post-herpetic neuralgia in your patients?
No, I think the sooner we get them on oral antivirals at the time of their rash, the better. But otherwise, I don't think the data I don't think there's much data to support oral steroids, which is what we thought 20 years ago. I don't think that's true, so I don't use oral steroids anymore. I don't think there's any way to prevent it other than the earliest use of oral antivirals at the time of rash.
Thank you, sir. I request any of the panelists to please ask any questions.
Thank you, Professor, for that very wonderful lecture. I have two questions. The first one is, in your practice, what differences do you see in the clinical presentation of a pediatric HSV versus an adult HSV? And is there a difference in the treatment regimen you follow for the two? And my second question would be that if you're planning a graft for an HSV patient, you did mention the use of oral prophylactic antivirals. But does your steroid regimen, use of topical steroids, does that also the regimen differ between a HSV patient and a PK done for any other etiology?
Great questions, thank you. I'll start with the second one. I use regular oral antivirals after. I'm sorry. It was PK. Was PK?
Yes.
The question was.
Yes. So post graft, does your topical steroid regimen differ from your non-HSV patients?
Okay. So, no, it doesn't. I'll use the regular post PK steroid regimen, which for me is about 6 times a day for the first week, then 4 times a day for a few months, and then slowly taper from there. So the steroid regimen doesn't change. Pediatric HSV. So pediatric HSV can be more bilateral, and you have to consider atopic disease. And in patients with atopic disease, children with atopic disease, they can have much more severe HSV. So I'm much more aggressive in managing those patients. And they go on oral antivirals very quickly, and it needs to be dose dependent on weight and age. But they're monitored more closely. I tend to be more aggressive because I want to really prevent corneal scarring to prevent amblyopia. And I follow them more closely.
Hello, sir. Thank you, sir. This is Lakshay. Thank you for the comprehensive lecture. So my only question is, you mentioned that after the onset of rash in zoster patients, within 72 hours, we should start antivirals. So does your treatment regimen change if patient presents 3 to 4 days after the onset of rash?
I will treat them within a week. So if they've had a rash within a week, I will treat them with the same dose of antivirals. After a week, I think it's probably too late. The FDA trials were on 3 days, and that's what's FDA approved, but I will extend that out to a week just because I think that there may be some benefit, no great proof of that, but the cost, whether it's financial cost or the risk, is very low. And the gain, if we can decrease the chance of herpes, a postherpetic neuralgia or keratitis or inflammation, I'll do it for a full week after the rash.
Okay, sir.
Hello, sir. Hi. Thank you for such a comprehensive lecture. So I have 2 questions for you. First one being, when you plan a PK for a patient, do you prefer putting those patients on prophylactic oral antivirals before the PK, or do you start it after the PK?
I'm not sure. I do both. Some patients I'll start before, some patients I'll start the day of surgery. I don't know whether one makes a difference, to tell you the truth. And we don't know in general, but having said that, you're talking about simplex. I'm sorry. For simplex, most of these patients are on oral antivirals before surgery. So if they're not on oral antivirals, then I put them on before surgery. And if they're not on at the time of surgery for whatever reason, I'll start them the day of surgery. But most of them, because they've had enough herpes in the eye to cause corneal scarring, I want to prevent new episodes. They're on usually acyclovir 400 milligrams twice a day, or Valtrex 500 once or twice a day, or Famvir 250 once or twice a day.
And the second question, in certain cases of neurotrophic keratitis, when we have secondary infections, how do you decide starting topical steroids? At what time point do you chip in with topical steroids and such?
That's a very difficult decision. If there's active bacterial or fungal infection, then I'm not using topical steroids at all. Sometimes it's pretty hard to tell, or you've treated the infection, you think the active infection is gone, and you still have a lot of inflammation, then I will often use steroids. Judicious steroids, it might be pred 2, 3, 4 times a day. I'm not starting them on pred every hour, and I follow them very closely. But it's really, the more inflammation there is, the more likely I am to use the topical steroids. The more infection there is, the less likely I am. It's a balancing act.
And another question about tapering steroids for those patients who have had recurrent episodes. Are there any markers or any set protocol you follow about tapering the steroids slowly? I mean, do you see the number of episodes they're having before deciding, okay, fine, this patient will go for these many months for steroids on active and that ways?
Yeah, again, that's there's no hard and fast rule that I use. In general, the more inflammation there is in the eye and the more scarring there is, the slower I taper the steroids, and the more episodes they've had, the slower I taper the steroids. So if someone has had, actually, if someone has one episode, they have a mild disciform keratitis, their vision's 20, 30, not much AC reaction, I may just follow them without steroids, because I know if I start steroids in that patient, they're going to be on steroids for a long time. So I may follow them. And one of the head studies showed that if you follow these patients, many will do fine. If they don't do fine, you can add steroids later, and they will do as well as if you added the steroids from the beginning. So it doesn't do them any harm to wait to add those steroids in those patients. So, I'm hesitant to add steroids in the mild cases. I will certainly add them in the more severe cases, and I will slowly taper them. And the more episodes they've had, the more scarring or inflammation they've had, the slower I go. And then you learn. If you taper too quickly and it flares up, you say, okay, next time I have to taper it more slowly.
Thank you.
And sometimes people will taper them themselves, and then they'll come back with a flare up. You say, I would guess that was too fast.
Thank you. Thank you.
Good evening, Professor Rapuano. This is Dr. Tulika. I would like to ask your regimen to carry on with the oral antiviral after cataract surgery.
There's no hard and fast rule. I think that as long as patients are on the topical steroids after cataract surgery, the higher dose topical steroids, they should probably be on an oral antiviral. And then I would continue it for at least 6 weeks, maybe 3 months. And then if patients are doing well, then they may or may not need it after that. It depends again on how much inflammation, how much scarring they have, things like that.
So would you prefer to give them prophylactic dose as ACVH 400 mg BD?
Yeah, that would be the dose I would use.
Okay.
400 twice a day dose.
Okay. And I have another question regarding PTK. So what is your experience of PTK in post-viral scarring on the recurrence mostly?
Yeah. In general, I do not do much PTK for herpes simplex scarring or herpes zoster scarring because the scarring is too deep to be a good candidate for PTK. Having said that, I have done it a few times, and for herpes simplex, I will put them on oral antivirals, usually starting the day of surgery, because theoretically, it can be flared up by the ultraviolet light of the excimer laser. I've never seen that, but I've always put patients on antivirals, and I'll put them on for usually a couple months after the PTK just to make sure it's not flaring up. But I must say, I don't do much for for shingles or simplex scarring because it's usually too deep.
Thank you, sir.
Hi, Professor Rapuano. Thank you for such a wonderful lecture and giving us a lot of small clinical pearls. So this is Dr. Vikas. So my question to you is, sir, that in patients of post-herpetic simplex PK, when you have recurrences of the epithelial type like geographic ulcer in the graft, then how do you manage those, and what is the steroid regimen that you follow at that time, since these patients are already on steroids and have come with an epithelial disease?
Yeah, that's a difficult problem. In fact, I have a patient I'm following right now who had that exact problem. It's actually her third transplant. Original was for herpes simplex. She came in about a week or two ago on pred. I think she was on pred twice a day and came in with a new dendrite. So I treat these new dendrites with full dose oral antiviral. So for acyclovir, that's a 400 milligram 5-time-a-day dose for simplex. And what I did in her is I cut down her pred to once a day. And then in a couple days later, it was improving. I kept her on the same regimen. A couple days after that, it was no longer improving. So I stopped her steroid because I need to get this. Now it's actually becoming a little bit more neurotrophic appearing. I kept her on her oral antivirals because that's not toxic. And I stopped her steroid and actually put a bandage lens in. So, and these patients with post PK herpes simplex, we know they're gonna have a hard time healing. So I try not to use the topical antivirals because I think they tend to be a little bit more toxic. I'll use the oral antivirals in those cases. Whereas if I have a patient with their first episode of a dendrite, then they can easily be treated with a topical antiviral with no orals.
So my second question to you is that in patients who have had multiple recurrences, even with slow tapering of steroids and prophylactic Oxervate, do you step up the dose of prophylactic Oxervate beyond 400 mg BD to maybe 400 mg TID or 800 mg BD, something like that? And how often do you have to do that?
Yeah, it's unusual to have to do that, but I have some patients where they seem to do better. And when they're on the 400, 3 or 4 or 5 times a day, they do better than on twice a day. So I will do that on occasion, but I don't have to do it that frequently. I think if they're immunocompromised, they do maybe require a little higher dose, but I don't have that many of those patients either.
And so my last question to you is that patients of HSV that you are planning for PK and have a lot of vascularization. So do you do anything for the vascularization prior to the PK, like an anti-VEGF subconjunctival injection or anything like that to reduce the vascularization before surgery?
Yes, it depends on the amount of neovascularization, but sometimes I will do it just in the office, let's say a couple months before the PK, or sometimes I'll do it in the operating room at the time of the PK. Those are usually the milder ones, or I think I'll just maybe do a little bit of help there. But yes, I will do that. Having said that, before, 20 years ago, before we had anti-VEGF treatments, we could take a herpes scar that was very vascularized, do a PK, and the blood vessels would just disappear over time. Not all the time, but often, once you got rid of that kind of nidus, that huge area of scarring theoretically, but maybe some active was in there, the blood vessels would go away. But now that we have anti-VEGF, that's easy to do subconj, either a month or 2 or 3 before, or at the time of surgery, I'll usually do that, yes.
Okay, thank you, sir.
So we have one question from the YouTube. What is the role of PCR or Goldman-Whitmer coefficient for the diagnosis?
We do not use that much. I hardly ever use that because usually it's a pretty easy clinical diagnosis to make. We will do it on occasion. We'll send the PCR out if we've had a patient that we just can't figure out what's going on and we suspect it, but not that often. If we have significant intraocular inflammation, then we may do an AC tap and send it for PCR for herpes simplex, herpes type 1, type 2, zoster, and CMV, because CMV is often hard to diagnose.
Thank you so much, sir. We have covered all the questions. Thank you for patiently taking all the time.
There are no more questions, then it's my pleasure to thank Professor Rapuano for his wonderful talk, information laden. I'm sure it will stimulate a lot of discussion among the residents, and for being part of iFocus. Thank you so much.
And Hanavar, thank you very much. And it's been a pleasure to participate. Thank you again, and have a wonderful rest of your evening.